So, Leora, we've talked about Pacific. We all agree that it's changed the standard of care. How's it changed your practice? I know patients are to be randomized within 6 weeks. That kind of changes. How do you document lack of progression? All those sorts of issues that are now new since the results of the Pacific data.
So it's amazing how often you have to argue with a company that this patient does need a CT scan, even though they had one 7 weeks ago. So we do a CT scan just the day or a few days before we're starting them on durvalumab. So after they've done concurrent chemoradiation therapy, we'll get a CT scan, bring them in, and assuming we do not see progression, we explain we're not looking for a response because it's early. We used to wait a few months before we did a scan, that we're going to get going with durvalumab. I think the other thing that has changed in practice is what do you do if you're giving carbotaxol? Because a lot of patients were getting weekly carbotaxol followed by a consolidation, and that was not allowed in Pacific. Right. And so, granted, those are often the less fit patients who you couldn't give cisplatin and etoposide, which has always been our preferred treatment. So there are a significant number of patients who we are giving weekly carbotaxol and potentially foregoing consolidation carbotaxol and starting those patients on durvalumab.
I have a solution to that. I give it as induction.
Yeah.
Yeah, which with 28% of the people on Pacific had induction therapy, so I think that's a reasonable strategy. There's some, in the initial design of Pacific, they were supposed to be randomized within 2 weeks of completing chemo rads, but that got changed to 6 weeks because of the obvious accrual issues that were ongoing. That data, there is some data from that analysis suggesting that starting it earlier is better. I have two questions. Do you believe that? And secondly, does that change your management strategy during chemoradiotherapy, that you want to be more aggressive in managing esophagitis so they're in better shape, they recover faster and all those sorts of things? Or what are your thoughts there?
So I think it's hard to manage not only the esophagitis, but just the fact that people are fairly beat up
Fatigue.
after 6 weeks of concurrent chemoradiation. So that we talked to people that there was data that potentially starting earlier is better. Who knows if it's because of the radiation, and so you get more of that abscopal effect, or who knows if it was those patients who started early were just the better actors.
Better patients.
So they were going to have a better prognosis regardless. We do try start within 2 to 4 weeks. There's also been patients who at 6 weeks aren't quite ready, and a week or two later we're starting durvalumab. So it sort of can swing with both extremes, but I have found that most patients within 2 to 4 weeks we are able to start them on their durvalumab.
Okay. The only other thing to point out is the schedule. Since the schedule is more inconvenient compared to other immunotherapy drugs, I'm actually curious to know what my colleagues think about Q4 delivery. Would you be comfortable with that?
I haven't done that. I haven't had, in my practice, I haven't had a lot of pushback about the every 2 week schedule. I know we are opening a trial of looking at durvalumab after SBRT in those stage 1 medically inoperable patients, and there the schedule is every 4. I do think that adds
double dose every 4.
Yeah. So I think that adds a convenience, but I haven't gotten much pushback on the schedule.
No,
we only see them once a month, but they come every
Perhaps
other
the
week.
Maryland patients are a little bit different. We have gotten a little bit of pushback about that, and we've opened a trial actually through the Big Ten or Hoosier Oncology Group, which looks at just 6 months of either Nivo or Nivo Epi, where the Nivo is every Q4 weekly. And actually the schedule has been the reason why some people have preferred that.
Yeah, I think the traffic's worse in Maryland.